the quite dilated calyces and infundibulum, so I don't anticipate puncture to be very difficult. Here you can see this is a lateral most calyx. So I am anticipating my puncture into this calyx. Is it visible? Yeah. So I am anticipating my puncture into this calyx, and let's see after RGP, we'll take it. And from there, I will try to remove all this stone. Like this. That different?
Hello. I request Dr. Lal Malani sir to give a memento to Dr. Gaurang. Please, sir, come onto the stage. The other two, Dr. Shabir is not there. Okay. I'm sorry, the mementos are not there. So we'll have to wait.
कहाँ पे त्रिवेंद्रम वो जो हाँ समझ गया अच्छा उसमें हाँ उसमें वो तो ऑनलाइन था वो देना स्टेरिलियम देना मेरे को प्लास्टिक एप्रन है क्या
Aditya,
यस सर
when when I do supine PCNL,
यस सर
you know, two mattresses, I just separate it out.
सॉरी सर आई मिस्ड इट कैन यू इंक्रीज
To elevate, see, you want this space, na?
यस सर
So what I do, there are two mattresses, right?
Yes.
One above this thing, towards the head side, and second is towards the leg side.
या वन
So if-
behind the shoulder and one is
So if you just separate it, na,
yes sir
you will get enough of space.
separate it in the sense sir I did not understand
They are in continuation, and but there is a
okay you are saying if we use two separate matrices
Yeah,
one
yeah.
yeah I think that's a very good idea I think it can be implemented it will give even more space because we don't need that if the
Exactly.
that part of mattress is cut out or something it can be customized for that that will be really amazing. But last case, like I demonstrated, superior calyceal puncture, normal concern is whether we will be able to do all the stones, whether we will be able to do all type of stones, staghorn and everything. So puncture from the superior calyx is almost the same as the puncture happens in prone PCNL. We go enter system from the same place where I do it in prone. In inferior calyces, the punctures are more lateral. So that what is the disadvantage of that? The disadvantage is the tracks are longer. So longer track means too much mobility. Slight restriction of the nephroscope mobility can be there, but we can use it to our advantage. So the longer track we can align our puncture direction with the longer track in the line of the infundibulum and the calyx.
Yeah.
So this also becomes an advantage in that sense.
Yeah. So if you go to see, na, if the person weight is more than like 120 kilo or something, then in supine the tract, the lower calyceal tract are very, very long, and your amplar sheet may almost go up to subcutaneous.
Yes, sir. That's why this like stores nephroscope which I used in last case. They also have a supine sheath which are longer than the normal.
So that is a 20
metallic sheath
centimeter.
they give.
That is how much? 25 centimeter.
Yeah, yeah. Okay. So I'll be
Yeah, there is a change of
forward
guard.
going at who is assisting?
Dr. Gaurang sir,
Somebody-
Dr.
So you are
Suresh
there,
and
no?
Dr.
हाँ.
Amit.
Contrast चालू
Would you
capture करा हुआ है
kindly
ना?
chair the sessions?
So to save time, we had already uretic catheter was already put. Now I'll just straightforward go ahead with it. I can just demonstrate the surface landmark again. This is the posterior axillary line. This is the tip of the 12th rib. This is 11th rib. So sometimes if you don't mark it before positioning the patient, the landmarks change. One should always mark when the patient is in anatomical position or straight position. Now, even if this marking gets wiped out while painting and draping, So one should
Dr. Ravi, please
remember that how
come onto the
far
stage.
the tip
Please
of 12th
change
rib
the
was
session.
from your initial marking.
Yeah.
So this was the
Dr.
this is the tip
Rajesh.
of 12th rib, and always try to remain behind it. So normally I take landmark
Right.
tip of the 12th rib,
Myself,
but it is
Dr.
a
Amit
floating
Sharma. I am
structure.
associate professor at
Sometimes
AIMS
it can be
Raipur.
short. Okay. Give me the fluoro pedal. ऊपर ऊपर लो, ऊपर लो, ऊपर ऊपर, पीछे लो थोड़ा, थोड़ा पीछे लो, हाँ, ऊपर लो, ऊपर, ठीक है. So we have passed the ureteric catheter in the superior calyx. थोड़ा सा आगे लीजिए, थोड़ा सा आगे लीजिए, आगे आगे. अच्छा, ठीक, ठीक है. इसको इमेज को हॉरिजॉन्टल कर दो, इमेज को ऐसे हॉरिजॉन्टल कर दो, फाइन को हॉरिजॉन्टल, अरे फ्लिप नहीं करना है, इधर रोटेट, फ्लिप नहीं करना है, जस्ट रोटेट द इमेज, अपोजिट अपोजिट अपोजिट, मेक स्पाइन हॉरिजॉन्टल. वाह, perfect. So this is the position. So can withdraw a little bit. Am I live?
Yes, you're audible.
Am I audible in the hall?
Linear.
थोड़ा सा, हाँ, okay. So we have put the ureteric catheter in the upper calyx. There is one advantage of keeping the catheter. The assistant can keep flushing the ureteric catheter. So that also blocks infundibulum of the upper calyx a little bit. So the stone fragments don't migrate much into the upper calyx. Because in supine position, the upper calyx is more inferior. So the gravity dependent stone dust may go and settle in the upper calyx. So now put the contrast. इसको इधर ले लो, इस मॉनिटर को इधर ले लो, वो मुझे दिखे. एक मिनट, बस बस, ठीक है. ओके, पुश पुश कॉन्ट्रास्ट. जाने दो, let it fill. It's a quite dilated system. It will take lot of contrast. डालो डालो और डालो. Yeah, so you can see this is the calyx which is lateral most. So I intend to enter from this calyx, and on the surface I have to mark my puncture in a way. Now needle is here, so we have to go behind the posterior axial line, and wherever that needle meets in that direction, from there we take the entry point. Knife, knife. Now the same principle we have to see first. If I am hitting the kidney respiratory movement of the kidney stops. So that is one way of knowing that in one direction I am going correct. You can see now the kidney is getting pushed by the needle. I can slowly progress. You can even see the indentation of the calyx. Now it looks like I'm inside. Let's see. Oh, it's come out. Needle is बहुत rough जा रहा है ये. क्या है ये? ये बहुत रफ जा रहा है, स्मूथ नहीं है नीडल इसमें ना, वेंट भी ये नहीं आ रहा है। वो दो, ऑपरेटर दो उसका, उधर नीडल दो। और ये देखो इतना मूवमेंट हो रहा है हाथ। लेजर लेजर ले लेंगे। रोटेट द सीएम, ऐसे ऐसे जाना है, ऐसे जाने दो, जाने दो। तो नीडल इज गोइंग अपोजिट, so I am slightly posterior to the calyx. Zero zero, if I may not. So water is coming, but I am inside the system, quite dilated system it is. Okay, you can give me the knife. Chair यहीं पे लाके रखना है ना, I'll have to sit. See, in entire dilatation, puncture, an entire process, not even once surgeon hands or any part gets in direct exposure of the X-ray field. And the position, I am also standing at least 3 feet away from the area of radiation exposure, so that reduces the radiation to surgeon also. Yeah, take it out. Same वैसे ही करेंगे. I will just do a two-step dilatation. There is a first facial dilator. This is how much? 10? 10 French? 15, yeah. So you see, if I'm going like this, you can see the buckling over the, you have the C-arm view. You can appreciate the buckling of the guide wire. That means my direction is not correct. So one has to be in right direction where the guide wire buckling is not happening. Skin कम कटा है थोड़ा सा. Knife, give me the knife. You see now there is no buckling. So one has to, while dilating system, one has to be conscious that if there is buckling, then one can push above or below the kidney and create a space there. And over dilatation should always be avoided. Just enough to enter the calyx and water is coming from here. So that's good. You can give me the next dilator. लेजर वगैरह रेडी कर लो सब चीज. एक चेयर यहाँ पे लगा लेना है ना, लगाया ठीक है. इससे साइड से भी डल जाता है, ये देखो, ये ऐसे साइड से है ना इसमें चैनल. दो गाइड वायर का जगह है इसमें. कैन पास another guide wire also from that. Just see if you can pass it from here, this channel. Another guide wire is there. Just show guide wire low. Just pass it from here. So we can keep a safety guide wire if one wants. Going na? Nice, nice. Just give the soft end only na. Okay, when we pass na other guide wire, so to the outside the exchange. Yes. So with the gentle screwing movement,
Hello, Aditya.
yes, sir.
You want to put a safety guide wire?
I wanted, I
Then, if
generally,
you are if you are planning to put a safety guide wire, then your the outer ampla sheet should not go right now.
yeah, it has to be put once I
Yeah.
put both the guide wires. That becomes two-step process then.
Huh.
What I do otherwise is I use, it's not a very popular instrument, I Alken needle and cannula.
Hmm.
Through that I put a additional guide wire.
Yeah.
So that saves me the first dilator I put, generally Alken needle and cannula, where the facial one I used. Instead of that, I use Alken needle cannula. And through that, I pass a safety guide wire.
And do you routinely use the safety guide wire for all PCNLs?
Not mostly demonstration, because many times, it is a concern from audience that there is no guide wire, but no, normally I don't put.
Okay.
Very rarely, if there is too much impacted calyx and I'm just at the tip, I worry that I may slip out of the system easily. Okay.
You already entered the calyx, I think.
Actually, there's friction between
The other thing that you
outer
can
and
do
inner
under
sheath.
vision.
Outer and inner sheath is some friction is there.
अच्छा, निकल नहीं रहा है.
नहीं, उसको बाहर नहीं निकालना है. Okay, so I'm inside.
Yeah, what difficulty are you facing right now, Dr.
Actually,
Aditya?
there's some friction, I think, the between the outer sheath and the inner dilator. Some friction is there because of that. I think तो lubricate करना था थोड़ा सा ताकि वो ली जाए. I'm just.
What size sheet you are using?
This is 21, sir.
21.
Large stone, so I.
Mini
I-
nephros. And which nephroscope you are using?
It stores 12 French mini
MIPM.
nephroscope. Yeah. So
I think
scope
this
करो.
sheet is meant for MIPL.
This sheath, sir.
Hmm?
Hmm. This is going live now. Put. Light on करो. Light on. Light on. इसको बकेट में डालो. इसको बकेट में डालो. ये पकड़ लो, पानी गिरता है ना. इसको लगा दो. डाल दो. बंद नहीं, नीचे टच हो गया, छोड़ दो. Just hold it for now. Okay, I'll just see whether I'm inside the nephroscope. जनरली पहले ही लगा लेना चाहिए. Okay. Even if we are using mini scope, the advantage of large outer sheath is bigger fragments keep coming out. So here is the stone, and the guide wire, I can remove the guide wire at a stage because this guide wire also reduces the lumen. Okay, give me the laser. मेरे को बैठने को दे दो. So now I can comfortably sit and operate. आगे बढ़ा दो. Chair आगे बढ़ा दो. हाँ, पैडल. सेम सेटिंग रखो लास्ट टाइम जैसा. हाँ, टू कर दो. 2. We want large fragments, so we have kept energy at 2 and frequency at 10. So we are using thulium fiber laser. This is a IPG thulium fiber laser. Ready? You can keep flushing from below, na? Give 50 cc syringe to him, he'll keep flushing the ureteric catheter. So as I told, the flushing is important because it helps in it distends the system, one. It prevents migration of stone fragments to upper calyx because that is the most dependent calyx in supine position. All the dust which I make, it keeps coming out by the side. So I don't have to use forceps for removal. Even in large fragments, they also come easily by the side. So now I use supine PCNL for all my cases for almost 5 to 6 years now. So all type of stones and cases can be comfortably done. And the added advantage is, like yesterday we had a discussion about how to give complete absolute clearance to patient. How do we ensure that? The best way of doing it is actually if you pass the flexible scope in the end and visualize every calyx and confirm that you have removed all the stones. फ्रीक्वेंसी बढ़ सकता है 20 कर दो We are using Olympus camera. Very hard stone. So, Mulawkar sir, are you there?
Yes, I am very much there.
Yeah. So I wanted to ask, like, in your opinion, do you think these stones are better handled with lithoclass? Just pneumatic works wonderfully, in my opinion.
Actually, what happens is once you get this laser, now you are habituated and you get addicted to using lasers because then you do not have to remove the fragments. With lithoclass, you have to remove the fragments. Then that causes a lot of movements on at your shoulder joint,
Hmm.
and sometimes my shoulder joint pains. So I use laser more often. So that's for my convenience.
Okay. Okay. But the advantage with lithoclass is like it just breaks 4 or 5 pieces.
Yeah.
And now it's with the best efforts, it's still dusting. I'm not able to make
No,
large fragments here.
in this patient, you are using a 21 sheath. So you can very well use a lithoclass, just make it 4 or 5 fragments, take it out.
Yeah. So with normal nephroscope, we'll
Yeah.
have to use for that.
But if you are using a
Mini, yeah.
16 or 16, 15 sheath, then laser is the best option.
Through mini also, many people use 0.8 probe and do pneumatic lithotripsy.
Yeah, yeah. Yeah. Yes, sir. Oh, any scope. No, all scope will go. All scope will go. No, no, no. No, no. Depends. Aditya, what setting you are using?
So it's now 2 and 20,
2 joule, 20 hertz,
15 hertz.
15 hertz.
Very hard stone, so taking own time.
Dr. Adit,
Sir,
is there any limit of stone size for you to decide between laser and pneumatic lithotripter?
personally, larger and harder stone, I prefer to break them in 4 or 5 pieces, large sheath. Many times I use 24 French
No,
dial
what is
sheath.
the size of stone? Is it like 2.5 more than 2 for your personal
One is
borderline?
hardness for sure. Very hard, then I prefer using large stone, maybe 2.53 centimeter, more than that. If I'm using normal Ampla sheath, any size 20, above 20, I use a pneumatic.
Okay, like
Pneumatic
this,
is cost effective to patient also, because every case laser, I have a holmium laser, and every case patient has to pay around 15-20,000 extra. And PCNL surgery day by day is becoming like lap chole, I think gallbladder. So its costs are very low.
because this stone looks quite hard.
It's very hard, so definitely. So we have to see all the aspects, because cost is a big constraint, especially for patients who don't have insurance. So there, I find pneumatic, because uh, I bought it 70,000 rupees 4 years back. It's still working fine. Probes in between we have to change. Each probe lasts quite long. So, uh, but
Okay,
RIRS of course, and mini perk we use laser.
okay, fair enough.
Once the bulk thickness reduces, then it will finally break into larger pieces. As of now, it is only coming out a small pieces. These all small pieces are getting washed out by gravity drainage. So nothing remains as such in the system, or it is not going in other calyces. You see now thickness is less, so it broke into larger piece.
Hello. Dr. Aditya,
Yeah.
I just want to ask, as you say, is last 5 to 6 years you are doing only in supine PCN only.
Mm-hmm.
Suppose you are working in some institution where you are teaching some residents. So you will directly teach them a supine PCNL, or ask them to do first a prone, then go for supine.
Yeah, I've personally almost 20 urologists have worked or trained with me, under me. So all are doing only supine. So none of them has gone back to prone.
Okay.
One
You
has
have.
to give enough time. I think many people see, if you are driving left side of the road or right side of the road, it may feel the same, but you can't keep switching left and right every day. Once
Yeah.
you are in US, you take at least a week to getting used to driving on the right side. So
What
that's
I
like,
think that is a practical problem. What is happening in India? Just people first start with a prone. They start learning a prone, and spending 5 6 years in learning prone. After that, they are shifting to supine.
no,
And
the basic principles of stone dusting, fragmentation, and how to handle scope, everything remains same. So that comes to advantage only.
Mhm.
That's not a disadvantage. One knows how to, after entering, what to do. So after entering, everything is same. So that's an advantage. I would say, prone, that's good thing. But why people don't have? Because most teaching institutes, as such, there is not much exposure of supine. I'm saying with me, whosoever has worked, juniors, they have all learned supine. Because many did not know even prone also. They
Okay.
grasped it very early and very well, and they are still practicing. They are in various institutions, North India and South India, and they are everywhere they are doing. And my approach is, wherever I have gone for an operative workshop, I motivate the primary person who is organizing the workshop. I went to Kochi, Sandeep Prabhakar and Yunus, he was there in his team. And they, afterward, they just switched to supine. Dr. Chandramohan sir's conference, I went, And after that, he is supine man now. He is not going back to prone.
Okay.
That's not actually difficult actually. There are only two concerns people have. Will I injure colon? Will my puncture happen? Once inside, if I can ensure that puncture is surety, there is no, so far with me in last 6, 7 years, not even in a single case, it happened that puncture did not happen.
Okay.
Puncture will happen once you are inside, then what is the limitation?
Okay.
There are only then patient-related limitations are there. There is sometime bleeding, something, and then you have to stop. Bulk is more. You have to stage. Those are common factors. Only difference is there's no choice of stone as such. Only difference which I feel is in supine the entry. Entry one has that too particularly because we are approaching puncture from the lateral side. And I see many prone PCL surgeons, they use a freehand technique. They just land on the kidney and they puncture. It's the same thing. I am just doing same thing laterally, and I have standardized certain ways to confirm whether I'm inside. How do I do my course correction? If I'm not inside, what should I do? So all those things are required. But learning wise, there is no difference. I think it will be slightly difficult if one learns bullseye. Bullseye is a easy puncture. Bullseye puncture is not in line with infundibulum and the calyx. Your puncture falls directly on the calyx, then you turn the scope in the line of an infundibulum. In the lateral punctures of the free hand. Okay.
Hello, Dr. Aditya.
Yeah.
The second OT is also ready.
Yeah,
So,
no problem. I'll just finish up this and
Sure,
we can come back in the end.
Yeah, can we
Thank you,
switch
sir.
on to this second OT, please? Yeah, Dr. Hiren is operating.
पानी डालते रहे भैया ना ये विजन इसमें ऐसा जा रहा है क्या चक्कर हेलो तो मेरा फोन किसके पास है मेरा फोन किसी
You
के
hear
पास
me?
है
Yeah, we are able to hear you.
So this is a second OC RIRA case. Dr. Hiren is almost ready. I'll just hand over the mic to him.
Yeah. Can you switch it on? Force it. Hello.
Yeah, hello.
Yeah, can you hear me, please?
Can you be a bit louder?
Yeah. Can everybody hear me?
Yes, yes.
So we are going to start an RIRS case. Patient has got a 12 by 6 mm stone in the right kidney, and he has been pre-stented. So we are going to remove the stent and put the glide wire through the DJ stent. Water on, please. Water. बराबर है कुछ नहीं ये पकड़ I'm just starting the scopy to retrieve the stent. Madam, start.
Can we see the
Light on,
X-rays, please?
Light, endo light. Can you give the endo view? Yes, it's on. Thank you. We are in the bladder and I'm going to retrieve the DJ. Just give me forceps, please. Rahul? Okay. Release. Fluoro foot switch. Fluoro. Show me the stent. हाँ. नीचे कहाँ तक आया बताइए. Okay. Light standby. Light wire. Zebra है क्या? Stent is encrustated, I think. Yeah. Let's take out the stent. Stent is encrustated, so we are going to put the guide wire directly.
वो रबर कैप था ना, वो लाना. बड़ा वाला ले लो, बड़ा वाला. दूसरे दो दिखाए थे ना तुमने. Okay, I am just finishing up the case. Am I audible there?
Yes, yes.
So you can see the entire stone is cleared. All the dust is just washed out with the gravity dependent drainage. And a few tricks I just wanted to show. See, from inferior calyx it is very easy because we are following the line of the infundibulum, the orientation of the calyx in infundibulum. So we can follow same, and I can easily enter the superior calyx from the inferior calycial puncture, which generally doesn't happen in when we are doing, prone. And last case I demonstrated from superior to inferior, you can move as much as it is possible, kidney allows, in the same way as in prone. So these gives added advantage, and there are studies which have shown around 80% of the time you can access, because this is very dilated upper calyx, so I may not be able to reach every part of it. But even if some small stone or some fragment is there, I can grab them there. So it is easy to enter from here. Middle calyx, again, if it is a compound large calyx, it is possible to enter that here. Here is the middle calyx. I can enter the middle calyx. So all the case is over. I'll just put the stent. Any questions are there, I'll be happy to answer.
You're planning to put a nephrostomy?
Not needed, sir. We'll do
Not
tubeless. So, end on bloodless puncture totally. So I'm not planning for a nephrostomy. And guide wire डालेंगे नीचे से. The other thing is, like, lower track is always in your control. If you are in doubt, have I left any? Can you show the fluoro? And I did not have to move. We'll have to see, is this some fragment is gone there or what it is? It is the contrast, I guess. You can flush it first.
Yeah, flush it with the ureteric catheter.
Yes, we'll see. Should not be any stone fragment. So it's a very dilated system. So possible that some fragments might go. So you see the, yeah, perfect, perfect. So I'm just winding up the case. Thank you, everyone. Thank you, West Zone. Thank you, Dr. Maurya, and for this wonderful event. And I'm really delighted to be working here. Thanks a lot.
And we all thank you from the West Zone.
Yeah.
Thank
Thank
you,
you,
sir.
Dr. Aditya.
Is that the residual fragment there? Just below the 11th rib?
Yeah, I'm just trying to flush.
No, you said you are winding up. That's why I was worried.
Yes. Where is the port seal? Port seal.
Doctor. Hi, Hiren.
Hello, sir.
It just
Yes,
shows
can
the
you
X-ray.
watch
We are
it?
not
There
yet
is
seeing
some
the
dirt
X-ray.
inside. Can you just? We have just managed to put in the access sheath. We could not negotiate the wire through the stent because the stent was placed 1 month back and it was encrusted. Encrusted it. So now access sheath is in place and I'm just about to start my flexible
No,
scoping.
show the preoperative X-ray. We are not got the preoperative imaging so far.
Okay, sir. Can you
Yeah.
see the endoscopic image?
Yeah, we can see.
Endoscopic image is there.
Yes, yes.
Yeah, Siam, can you show the access sheet, please? Haji. White balance. Off.
There is no white balance in this camera, I think.
Can we have the X-ray
So we
picture,
are
please?
using the BioRad scope now, and the Olympus P7 is also here. So at the end, we'll just use that scope because that has not been demonstrated as of yet.
Can we have the glimpse of X-ray, please?
Yes, please turn that side and show the CT images and the last line. Rahul, just tell them to focus on the last line.
Can we zoom it?
इसको flush करो हल्का सा.
You are operating right side.
Yes, sir.
Okay.
Right click. राहुल सर को आने दो.
Upper calyx.
So this is
Upper
the upper calyx. This is the renal pelvis. This is the middle calyx. These bubbles show that that's the anterior part of the kidney. And this is the lower pelvic calyceal system, lower calyx. Some Randall's plaques and one very tiny stone here. So we are going to use the 150 micron laser fiber IPG machine, 30 watts. Okay. Thank you, Rahul.
Actually.
This is a 150
Hiren, you are
micron
using
fiber. Which
thulium, not thulium
yes, sir,
fiber.
thulium. But this is a 150 micron fiber. You can see it is so soft that if the port seal is closed, I'm not able to, move it in and out like normally we do with the 270 fiber. It's very, very thin. Very, very thin. I am also using it for the first time. I think yesterday was the first time that they have launched it. So we are in the renal pelvis. The scope is straight and the fiber is out. Take this one. Yes.
What size
Ready,
access
please.
sheet you have put?
So I'm going to start dusting, sir.
What size access sheet you have put?
Sir, 10 by 12. It was a pre-stented patient, so 10 by 12 we started. I'll see if I can move the stone up a bit. Rahul is just helping me with the flush so that we can, yeah, we can move it in the upper calyx. Yes. Oh, yeah, yeah. Yeah. I've got the stone in the upper calyx, so it's absolutely right in front. You can leave it. Respiration control, please. Yeah. So we are dusting. I'm trying to remain just on the surface of the stone. There is some movement from respiration. I'm trying to use it to my advantage. Have you got a good endovision?
You got the excellent endovision.
Okay.
Hiren,
Yes, sir.
which different flexible ureteroscopes you have used so far, and what was your experience with those scopes?
Sir, most of the times I've used a Karl Storz flexible scope, the Flex X2 and the Flex X2S.
Yeah.
Maximum number of cases I've done with that scope.
Mm.
And I feel that that is the most durable scope in the world even today. But definitely the vision that a digital scope gives you is far, far superior compared to the fiber optic scope. But this new scope from BioRad, sir, I'm really happy with this scope. It is very light, so my shoulder is much more relaxed. My wrist and thumb is relaxed. With the FlexX 2S, the problem was the weight of the camera and the light cable.
Yeah.
It really has tired me, and my shoulder aches sometimes. But with this BioRad scope, I'm very happy with the vision and the lightweight, and also it is 7.5 French.
And
I also used the UMD scope recently, and here also yesterday we used it, and that also is good. But I think that this scope is very good. And the FlexX from Olympus is also here. It's a P7, which also I have used, but I feel that it's a little more stiff in the shaft compared to the Karl Storz scope.
what about the XC?
FlexX C, yesterday, sir, I demonstrated with that scope. It's an excellent scope, excellent vision, but there are two disadvantages. One is you need the bigger access sheath, and sometimes in a non-dilated case, you may have a problem just if you have only that scope. Plus, the cost of the scope is quite a lot. So to maintain a FlexX C, it's a little bit difficult. But I believe Karl Storz is in the process of launching their disposable scope, which is going to be called the FlexX C Plus. Little bit flush, please. Okay.
Hi, Hiren sir. Harshvardhan here.
Hi, Harsh.
Yeah. Actually, as we were discussing about the sparking effect, now in this stone,
Yeah,
no sparking is seen at all.
that stone's composition only you could see, no? This
Yeah.
is bright yellow, and that was a little hard stone.
Yeah, hard stone.
So, and you can see the gravel formed here is much finer.
Yeah, sir.
yesterday my stone which I was doing was similar to yours. It was
Yeah.
a little hard stone. So in those, now here you see in the middle it's a little brownish.
Yeah.
That was what was happening with your stone also, that in the
Yes.
core it was a little hard.
Right, sir.
Hmm.
So you have used both thulium and holmium lasers. In case of a isthmus stone in a horseshoe kidney
Yes, sir.
or in a inferior calyceal stone, I guess still in these scenarios, holmium has an upper hand to thulium because the vibration effect of holmium is quite effective to take out such stones from the isthmus or an impacted calyx, where vibrations can make the stone come out of a calyx which is not very easily accessible with the scope. What is your take?
So you're saying that the vibration helps you
Yes, yes. In
to
these
dislodge
scenarios
the
only,
stone.
in
Okay.
such scenarios.
Well, most of the time I've used holmium. It's only now that in the last 2 years that we have started using. I think that's for all of us that we have started using thulium fiber now.
Yeah.
Earlier we all used all the difficult cases. More than 3,000 flexibles I have done at RG. All were difficult cases, and all the time we used the holmium laser only. So it is, yes, that advantage is there that the stone vibrates along with the vibration of the laser. You're absolutely right that in a very badly impacted calyx, stone in the calyx, it can help. But the dusting property of this laser is fantastic.
Fantastic. No doubt about it.
Now this stone is a little bit brittle, so it's tending to break also. In the end, we'll do the popcorning for those broken fragments. Respiration.
Still with thulium, there is a little bit of fear of using thulium fiber for proximal ureteric stones or any ureteric stone. I guess this is a myth, I guess, because I've been using thulium fiber in many of the ureteric stones. No mucosal burning or any mucosal injury is seen with thulium fiber. What is your take, sir?
The trick is to be very, very, very careful with the energy settings.
Right, sir.
You must use it to the lowest minimum and not use very high frequency in the ureter
Exactly.
and break from center to periphery without touching the mucosa.
Yes, sir.
See, occasionally the respiration is just making my scope dig into it. Yeah. Now I move to
Hiren,
fragmentation mode.
Hiren,
Yes, sir.
in your setup, you use a mechanical ventilator or a handheld ventilation? For
Sorry,
the
sir, I didn't get your question.
you use mechanical ventilator or a handheld held
No, no,
ventilation?
sir, mechanical ventilator.
Mechanical,
With low tidal volume.
low tidal volume,
Yeah.
and that means there are
Here
no
the
apneic.
problem is that they don't have the machine, they're hand ventilating.
Yeah,
Madam is doing a fantastic job, but in the middle, sometimes she has to give some respiration because of the carbon dioxide accumulating.
Hiren,
Yes, sir.
now for a smaller stone, sometime you try in the spinal anesthesia and ask patient to hold breath. It is much easier,
Yes, sir.
you know, because if the patient is cooperative
Yes,
and the
sir.
stone is not very big, it becomes much simpler.
So, Gauramsha sir, earlier I used to do all the cases in spinal only. The same trick we used to use. But after some time, I noticed that at times patient gets more apprehensive looking at the screen. And when we ask to hold the breath and looking at the stone, he starts taking much deeper respirations because of the apprehension.
So that is what I'm telling you. Tell him to leave the breath. Means what you have to do is tell him take a deep breath, leave it, now stop it.
Because
You know,
we need the irrigation
don't tell him
system,
to take a
which
deep
is
breath
made by
and
us.
stop.
Ideally, we should
Then
have the
you will be in
irrigation
trouble.
system.
And
So
you
there are
tell
two
him,
chambers
just
in
see
that.
the stone, what I'm doing. So please help me. And he will be more helpful to you.
I agree to that spinal anesthesia. You know, there were many papers that started coming in Europe as well. Sorry, about doing PCNL, RIRS in spinal. But frankly speaking, I am never comfortable. And I feel once in a while when the patient, even though is cooperative, becomes irritable and all those situations, then you just land up in having problems.
With the use of LMA,
LMA is good,
LMA,
yes.
it is best, sir. There is no
I,
throat
I do
irritation
many
also.
cases under
Yeah.
LMA.
And with workstation, you can go as low as
Yeah.
175.
Anesthetist
Tidal
is
volume
also
can be
happy
reduced
with
to
the LMA.
175.
And once in a while, you always have these spinal anesthesia patients complaining of headache, backache, not able to pee. All those problems I don't like actually. I like to do my cases under GA only. So ultimately, my stone is broken because it's very brittle. Yeah. That is why the Cook irrigation system has got two chambers.
Sir, what is your preferred method of using irrigation?
I like to use the Cook irrigation system, or you also have that syringe from Boston Scientific. But the Cook irrigation system is really nice. It's friendly. It has got two chambers, so the first chamber fills up so that there is no air that comes into the irrigation, and the other chamber is used for giving irrigation whenever required. So for all URS, RIRS, normally if the URS is straightforward, I use the Pathfinder. But if it's a complex upper ureteric stone or something, I like to use the irrigation system. It's controlled irrigation, plus there is not much high pressure generated by that.
Sir, you always use irrigation system in every
Yeah, I
case?
do, I do, I do.
Bec-
Either irrigation system or Pathfinder.
Okay.
I never have anybody mentally, physically pressing the bottle or giving forced irrigation.
Yes, sir. Some people actually say that short of Lasix may help and avoid
No, I
irrigation.
give it only to the end. I don't. Yesterday I saw somebody had given Lasix at the beginning of the surgery, but bladder fails and then you start having problems, BP rises, entry into the ureter becomes difficult. So I give Lasix only after I finish the surgery,
Okay.
not at the beginning.
See, the short of Lasix is not going to work because the water column that you are having here is at least 40 centimeter or 60 centimeter, and that much pressure you cannot generate inside the kidney collecting system by Lasix. So that is of no use as such. Rather, it just excretes urine from this kidney,
Okay.
opposite kidney. Doesn't help.
Yes, sir. Just a thought. Some people say like that.
Like people say that to prevent retropulsion of stone in ureteroscopy, you give Lasix. That's not going to work at all.
Now I'm doing popcorning because it broke into a few small fragments. राहुल हल्का सा फ्लश ऐसा हल्का सा प्रेस करना stop flushing. No, if there is some suction that comes, which they're developing, I believe we are. Come out of the calyx. Okay. Okay. Testing कर देना. ये साइड पे पॉपकॉर्न है ना.
Hiren,
Yes, sir.
these fragments are likely to pass?
Very tiny, sir. I'm going so close, it's as small as the laser fiber. I don't know. Can you appreciate there the
Yeah, we can.
endoscopic image?
Yeah, we can
If I come
appreciate.
far, sir, it's all gravel,
Yeah.
complete gravel. I mean, dust like dust.
So
So
why are you
whatever
still
tiny
fragmenting?
fragments I'm seeing, I'm just doing that popcorning now. In 5 minutes, I'll make it complete dust, sir. I'll show you the end result. This stone's composition was a little different. It was a very brittle stone. With a high frequency, it just broke into some pieces.
Hiren, how many patients you have seen that they come back with the recurrence of the stone after RIRS?
Sir, I confirm that I have cleared every stone. So either I have an endoscopic image which is completely clear, and then before the stent removal, like yesterday it was discussed, I do sonography, X-ray, and if there is a doubt, I do a CT. If there is a large stone burden, I do a CT. If there is any stone that is remaining, sir, while removing the stent, I do a chexcopy. The chances of that are less because I confirm intraoperatively that I have made every fragment. I have do good endoscopy. Now see here, sir, like for example, whatever small fragments you could see, that also has become into very fine dust. Can you appreciate, sir?
Yeah.
So if I have a picture like this, I am almost sure, then I don't repeat a CT. I just do a sonography or an X-ray. But even if there is a 2 mm, 4 mm, anything, then I have a look and usually I remove the stent.
Sir, do you ever remove the larger particles of the stone?
Sometimes I do, sir. I pick up some, if there are 1 or 2 pieces that are made while dusting, I just pick them up so that we can have something for analysis also.
Okay.
But earlier, when I started doing RIRS almost 10 years back, I was picking up each and every fragment. Like Lal Malani sir said yesterday in RP stone, he used to pick up every fragment. I used to do that when I started doing RIRS. I used to pre-stent every patient and every single fragment I used to pick up. But then as the time progressed, I started doing larger stones. And in larger stones, it's better to do this job rather than picking up. It becomes too tedious. You
Okay,
need
sir.
an expert assistant also to move with you with the basket. Now you see, sir, here my stone broke into pieces.
Yeah.
But the end result, if you can appreciate, it's so fine dust. And right now we are not irrigating because that just causes a snowstorm. But in the end, we'll again irrigate and see that we have not missed any fragment below the dust.
Do you ever do any investigations later on?
Yes, sir. I said if I have a doubt, I will do a CT, sir. But normally I confirm endoscopically and do sonography and X-ray before stent removal.
What about stone analysis in these cases?
I do, sir. I pick up stone for analysis. So 1 or 2 fragments I pick up and I always do the analysis.
No, this patient, the current patient you are doing, how will you do?
No, sir. Here we are not picked up any stone.
Okay.
Sir, what is the incidence of post-procedure complication like fever and other things in your experience?
When
Any?
I was at a center where I could not use a new access sheet every time, and they were doing reusing the access sheet, sometimes guide wire. There were a lot of problems. Many times I saw post RIRS patient getting fever and other things. But now I have changed my protocol completely. I don't use any wire, access sheet, anything which is used once before. And I also do urine culture. And that has really helped. It has really reduced. I have not seen in the last few years any urosepsis.
Okay, sir.
And also irrigation, sir. I am very careful with the irrigation. If you are careful with the irrigation, you are less likely to have complications. Any forced I feel any endourology procedure which is forced can cause complications.
Okay, sir.
So this is the dust that is there in the system. I will just remove my scope and empty it once so that we have some better vision. There is very fine gravel at the access sheath.
Hiren, is there
Yes,
any
sir.
way you can give wash?
Sir, sometimes with the urinary catheter, like how we give wash in PCNL, we have tried, but yeah, you can see it's all coming by the side of this access sheath. राहुल भाई थोड़ा फ्लश करेंगे. Let us just see if any fragment is left. We are just flushing to see if we have missed any fragment. Otherwise, it appears to be there. Stop.
At times, at the end of this procedure,
Yeah.
sir, it gets difficult to chase the fragments one by one. So in a compact calyx, what we can do is just keep the fiber in a steady position and go for popcorning or some fragmentation mode. The stones will come and kiss the fibers.
That is what we did, no?
Yes,
Just
yes,
now.
sir. Yes,
Just
sir.
5 minutes back we did that only.
Yeah, yeah,
Popcorning
yeah.
only
So
we did.
that is the trick after, because
Yeah,
the
it was
dust
in-
covers the stone particles.
Correct. थोड़ा फ्लश करना. रेड है ना वो निकल जाए.
Yeah, yeah.
We are going to introduce the Olympus scope because they want us to see once with that also. So I will just do a little bit of popcorning for 5 minutes and then shift to the scope, Olympus scope.
Okay, 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 sir.
Is the scope ready in the side edge? Okay. Sister, you can take it.
Is second OT ready? Can someone find out? Hiren?
No, sir. From here we can see there is no patient taken there.
Acha, but
Have they
are they
taken
going
the
to do anything on that side
I'll
or?
just ask Dr. Maurya.
Yeah.
Sir, are they taking anything in the other OT? They are asking. What PCNL they are taking, sir?
Because see, many people are going to leave. So if they can take it faster,
Yes, sir.
it will be better.
See, that is the quality of the dust, sir. I don't see any fragment there. We'll just remove the laser fiber and change the scope now. Stand by, please. I have put it on standby. Thank you, Rahul. Scope is ready now, so we'll just remove this.
Dr. Yogen is here.
Okay.
Dr. Yogen is here.
3 point.
Harshvardhan?
That is the standard size. Okay. Yeah. So one trick when you're using these fiber optic scopes is that you need to lock the camera. So whenever you use a Karl Storz camera, you attach it on the scope and then move it to the left and the camera is locked. Otherwise it rotates when you go in. White balance. लाइट ऑन करके वाइट बैलेंस कीजिए. लाइट इंक्रीज करो ना, लाइट. हाँ, दबाइए. अभी वाइट बैलेंसिंग करो. ऊपर 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 ऊपर. हाँ, ये वाला. Rahul bhai, flush kar. So I feel this scope is a little more stiff. This shaft is a little more stiff. They made that on purpose, I think, to help people, use it like a semi-rigid scope. The only problem with that shift shaft is that I feel is that maneuverability becomes a little bit difficult. हाँ, बड़ा कर देता है. Then the
Hello.
vision. Yes, sir.
Hiren sir, just 1 minute. Na?
Yes, sir.
Gaurang sir, can you hear me, sir?
Yeah, tell me.
Sir, there is Sir SK Paul sir couldn't come because he has to go outside of India.
Huh.
So he has sent me a recorded talk. So it's with the media person. Whenever you time, you can just play it. By that
Okay,
time, next
okay.
OT is getting
So
ready.
just now we can play because you are going to take some time.
Yeah, you can play, sir.
Okay,
Yeah, okay, right.
Most important step of this canal is making a short, straight access track to the cortex to the pelvic addition. Let us discuss today the three techniques of making.
Have you stopped the transmission? Can you switch off the mic? Stop.
In the renal pelvis, and because 80% of us do prone
Mic बंद
PCNL,
करो.
our patient is also lying prone position.
नहीं, खाली बंद करो.
Now let us start understanding the PCNL.
बंद किया ट्रांसमिशन.
Now, if this is our supine patient, please pay attention to the X
Hello. Yeah, can you hear me? Gorang sir?
Yes, sir, we can hear you.
Yeah, so case is I'm handing over the mic to Jan Kanaskar sir. He will discuss about the case. Can you zoom on this? X-ray?
Good afternoon, everybody. Here is the case of 45-year female. She has got lower calyceal left lower calyceal stones. And if you see carefully, there are two stones in the lower calyceal system. And IPV shows a good functioning kidney with a complex lower calyceal system. What we are planning is to go. Now, can you show this? We are planning a mini park for this lady. This will be prone. दिखा उधर 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 दिखाना. Okay, just give a second. We will be showing a Siam image and what puncture we are planning. एक बार केवल दिखा देंगे. तो वो पहले वाला दिखा सकते, प्लेन दिखा सकते, प्लेन सीट. If you see on the if you see on the plane exposure, there are two stones. One is big 2 centimeter, another is around 9 mm. These both stones are in separate calyx. So what we are planning to do puncture on the this middle calyx middle part, and so that we can come on the top and we can clear the both the calyx from above. Contrast फिर ले लेना. ये fill up करा. ठीक ठीक है. ये हिल रहा है कि नहीं? अरे यार ये है ना, वो है ना. आई फील आई एम इन द सिस्टम. कैन यू टर्न 30 डिग्री इस तरफ, 30 डिग्री टर्न. थोड़ा सा
Hello.
टुवर्ड्स माय साइड. या ओके. ठीक है, जीरो करना. ठीक है ना, अप कर लो, टेबल अप कर लो. इफ सी आई एम नॉट गेटिंग. मिला. यो यो लाइन लेना, सिरिंज लेना बेटा. हाँ, ये नहीं सलाइन, थोड़ा सा सलाइन इंजेक्ट करना. हाँ डालो. needle देना देखो okay, उसका स्टिलेट देना ये needle अंदर वाली needle this is contrasting देखना
Can you go little more superficial?
yeah I'm doing that line देना now with this little adjustment it seems that our puncture is in that desired calyx is there and now I'm putting a guide wire and let us see support करना पड़ेगा because of a stone this guide wire is getting stuck up there so when I park it the upper calyx yeah it is going there and I will park it there only
Push little fluid from below.
yeah they are putting I think I will leave it there knife देना पकड़ लेना guide wire just hold it there fine I will go with the facial dilator first water then give me next छोड़ दो. Mhm. The line थोड़ा सा ऊपर लेंगे. Yes. Down, down. थोड़ा सा सियाम नीचे. That's it. Give me sheet.
The guide wire is moving well.
Yeah, it is getting stuck up with the stone, but it is moving. You can see.
Yeah.
line डालना. जो push water. She is obese lady. That is why the surface to calyx distance is more. So our amplas is little bit more inside. Accordingly, we will be using a laser to fragment the stone because this is a 2 centimeter stone. Let us see inside, go inside and see what is the inside view.
Hello, Jayant. Jayant, Prashant here.
Ah, hi.
What is the size of the outer sheath that you are using?
This is 15.5 Carl store sheet.
Okay.
We are going for mini per.
So which laser system you are going to use? What fiber? And how much energy?
IPG thulium fiber is there, sir. And we will be going for fragmentation mode. Give me 600 micron fiber is there.
So which scope you are going to use?
This scope is, sir, Carl storage scope. 12 French. देखना वो गाइड वायर ना निकल. मॉनिटर सियाम थोड़ा पीछे ले लो. अभी सियाम पीछे ले लो. See, that is the stone. I feel that is the stone is the bigger
This
one.
is a lower callosal stone.
Ah,
Can you
that-
show us the second one?
Yeah. This is the our
Pelvis.
guide wire going toward the pelvis, and another one will be here only. The line नीचे से डालेंगे क्या? थोड़ा saline डालो तो clear होगा ये. Another one will be here because one was in that this clot is covering that calyx. Will be here. it
Yeah,
is.
that is the second one.
That
I
is
think you
the
should-
smaller one, sir.
I think you should tackle that one first.
Yeah.
Just remove it and then go for the bigger one.
Yes, sir. थोड़ा सा इस तरफ ले लो, ये पूरा निकल गया है, इधर करो। लेजर का वो मेरे पास है क्या?
To be very frank, I was little skeptic about the puncture, but you did it, manage it very well.
Okay, I thought I was going from that one of the cup of the calyx. That is a lower pole complex calyx. So
Why don't you just deliver it first? You know, you just deliver it.
Yeah, into the
may
main
be-
track.
If you got a small forceps, just hold it and just deliver it.
give me.
Because in case if it goes little deeper, na, you may have problem.
Correct, absolutely.
I'll do that. I don't know whether it is stuck up there or not, but okay, fine.
If you are comfortable with first,
I think I will just fragment it.
yeah,
it
yeah,
will
you
come out.
fragment. Yeah, I think
Because
whatever
it
you are
is-
comfortable, you please go ahead.
It is basically stuck up there.
Yeah, yeah, yeah. I think with the fragmentation, it will come down.
Yeah. कितना? 1.5.
So which,
I-
how much? Yeah.
1.5 and 16.7.
Okay.
Is it ready? इसको पास में लो. हाँ. Glass लेना. You see, sir, it is embedded in the mucosa. So
Yeah, we
that
can
is
see
why
it.
it is not coming out. So I thought that we will just fragment it and it will then we will able to drop it down. And that is why I did not puncture it from lower calyx over the stone, because it would have been difficult for going very perpendicular to take out this stone.
है ना तभी तो
The line. नहीं नहीं, ये छोटा वाला स्टोन कर रहे हैं, अभी बड़ा बाकी है, तो वी कैन शिफ्ट ओवर देयर ना टिल दैट टाइम.
Can you try to pull out that with the help of a forceps?
अब फॉरसेप लेके देखना, मैं उसको देखता हूँ मैनिपुलेट करते. स्टैंड बाय कर लेंगे. देना फॉरसेप. लेट अस सी वेदर वी विल. So that mucosa, can you see that mucosa over there? लाओ लेजर देना. ये रखो बेटा. गिव मी लेजर. क्या कैमरा? रेडी. अपन है ना वो नीचे वाले कैलिक्स से जाते ना, तो इसको नहीं टेकल कर पाते बिकॉज इट वाज ना ऑल impacted
Jain
badly.
sir has demonstrated a very fine puncture technique and now he's dealing with the stone. Now we will move to the next OT.
No.
Yeah.
For Kamlesh to
Yes.
address.
For Dr. Kamlesh Maurya sir. Can we move to the next OT? Dr. Kamlesh Maurya sir.
Water.
Thank you, Jayant, for an excellent demonstration.
It was impacted on stone, so I did not puncture from there, and that is why there was some difficulty for fragmenting it. Now we will be going for this bigger one.
Right.
You can shift to another theater. Thank you very much.
Right. Thank you, Jayant.
Hello.
Kamlesh, we are able to hear
Hello.
you.
Check.
Kamlesh?
Now एक काम करेंगे, इसको एम्प्लास को थोड़ा सा और अंदर डाल देता हूँ, तो दैट है ना, लेट इट बी देयर.
Can we make the full screen? Where? Yeah.
Thank you, Chairperson, Dr. Amit and Dr. Suresh.
Thank you.
For moderating the session. Kamlesh?
Yes, sir. Just 1 minute, sir. Yeah, now I can hear you. Can you hear me, sir?
Yeah, very well.
Sir, this was the last case for today, and everybody, I think, is a mood to go. So we'll wind up after this. I just want to thank everybody, all the delegates, everybody who is there. I couldn't come, so I'm sorry for that. And this is all my team, which has worked day and night. So this is my whole team, doctors,
अभी नहीं
staff,
लगेगा.
who are there. They have worked very hard, day and night. They have worked to make this a success. And I think we had operated around 15 cases in today's workshop. So I thank everybody. Thank you very much for showing confidence and coming here all the way.
Kamlesh, are you able to hear the applause?
Yes, sir.
Yeah,
Thank you.
everyone
Thank
is
you
so
very much, sir.
delighted. And
Thank
it was
you very much, sir.
excellently executed program. Congratulations to all the staff of Mark Hospital, especially the anesthetist and obviously the whole organizing team.
And of course, the He was the wonderful doing everything behind curtain.
And
Ah,
Dr.
great, Kamlesh, great.
Dr. Lalmanani, sir.
बॉस बहुत मजा आया
Thank
Oh,
you.
बहुत
thank
मजा
you,
आया
sir. Thank you.
अगला साल भी करना पड़ेगा तेरे को ये
Sure, sir. I'm always ready whenever you
क्या
say.
बात है क्या बात है
Kamlesh, one thing I want to tell you, I was just discussing, and because it is a small gathering, we have interacted so much with each other that, to be very frank, we have learned much, much more in this workshop than many other workshop. That is number one. And number two, the variety of cases that you had kept were mind blowing. Your staff, I must congratulate them that without saying anything, they have worked day and night. I was little skeptic 1.5 months back that how the things will go on. But looking at your hospital and your hospitality, I think anything you can, a time will come when you will be able to host even West Zone conference over here. So all the best to you.
Thank you. Thank you very much, sir.
Right.
Sir,
Thank you very much. And I
ये
take this
पूरा partial taste है.
yeah, I take this opportunity to thank all the pharma companies who have all the staff and the hotel people
How is
who have cooperated so
coloring
well and
around
contributed for the success of this workshop. Dr. Lalit, to say a few words.
I'm really very, very happy that with only 0.5% of my contribution to this workshop, this has been a wonderful, wonderful one. And I compliment all the organizing team, the West Zone, industry people,
पानी डालते हैं
Kamlesh,
तो क्या है ना?
Mrs. Kamlesh, Mark Hospital staff, and everyone. Absolutely wonderful. Even Yash for a excellent audio visual. In spite that I'm not very happy with this one, but still, okay. So thank you very much. It was a wonderful one. And we are very happy to have been conducting this program. Thank you.
Thank you very much, sir.
Thank you so much. And there were a couple of mementos which were to be given. I invite Dr. Lalwalani to come onto the stage to give the mementos to Dr. Suresh,
Can
Dr.
you see
Amit,
This is gone behind.
Dr.
that.
Yogen,
You see? ये जो है ना
Dr. Naveen,
इधर से ही आता हूँ फ्लिप हो गया है.
Dr. Harsh as well. Dr. Rajesh as well. Please come onto the stage. Dr. Yogesh, please come onto the stage. Dr. Ravi Batra. Dr. Tanzim. Dr. Tanzim, please. Dr. Tanzim, please.
रुक जाना, इसको बाद में प्रेशर से ये कर लेंगे। लेट अस
Thank you so much. Yeah.
ये डालते रहना तो है ना, इट विल कम आउट।
Dr. Guru, please make sure that. Yeah, Mr. Tyagi is here.
Sir, I think
अरे वो
good
थोड़ा
afternoon,
सा
everyone.
प्रेशर लगेगा वाटर
This
का,
is
है ना?
Tyagi. I'm from Intercardio. I'm really, I think, thanks to the Dr. Maurya and the thanks to the West Zone. It
fine.
was really as
अभी
a
है ना, इसको
wonderful
पकड़ना,
program. One
स्टैंड
thing
बाय
which I have
करियो।
realized, even I think, as a 2 days, I mean, 1.5 day programs, there are about more than 15, 16 surgery. And the important things like, all the surgeries
वाटर
were
वाटर
performed
प्रेशर
well. And
आई वांट
in
प्रेशर,
fact, I think it's a
क्योंकि ना
very
उसके बगैर
good
नहीं
message,
निकलेगा।
take home message to everyone, what has to be used and what things has to be followed. And I think everyone has been enjoyed, even. And I have particularly in a midterm, even I have not seen such kind of a program. I have not attended such kind of the beautiful program which has been organized in such a basically B class towns of India, even. So I really again thanks to the West Zone, thanks to the entire Chhattisgarh's, society, as well as to all the people, all the delegates who come from all different part of the the states and the country. And thank you so much, sir.
Thank you very much. As usual, we are very, very grateful to pharma industry for supporting us so happily, so cheerfully, and we always enjoy this. We have a very good rapport, and I'm glad that you are part of us.
Thank you so
And
much, sir.
the best part about the whole conference was so many of the scopes used were Indian.
Yes.
So I'm very proud of that.
Yeah,
Thank you.
sir. Definitely, we are moving towards all the Make in India projects of the Modi ji.
Thank you.
Thank you so much, sir.
Thank you.
With that, we wind up. And now I invite all of you for a lunch and then we disperse. Thank you so much. Lunch is on the same venue as yesterday.